Okay, so hi class, welcome to the online session. We are going to discuss today's session 5 slides, and this would refer to the slide 230, that is all about hemorrhoid, and then we have slide 81, that is adenomatous polyp, slide 209, that is another adenoma slide. We have slide 35, that is adenocarcinoma of the colon, and slide 107, that is carcinoid tumor. Okay, let's start. Okay, so our first slide is slide 230. This is thrombosed hemorrhoid. So thrombosed hemorrhoid is common, and it is associated with an elevation in the venous pressure in the hemorrhoidal plexus. And the hemorrhoidal plexus will be located at the anus and the rectum. So there are two classifications for the hemorrhoid, and it depends on its location. So if it's located in the anus, then it is lined by stratified squamous epithelium like this one. If it's found in the rectum, it is lined by simple columnar epithelium. When it is in the anus, it's called external hemorrhoid. If it's found in the rectum, it's called internal hemorrhoid. So this is what we have to look for, the lining epithelium, which is stratified squamous. And then we look at the stroma. You can identify for the presence of vascular channels. Okay, so you have thin-walled vascular channels here that would contain red blood cells. On this particular area here, you can see that there is a dilated vascular channel that is filled with red blood cells, fibrin, and this is a thrombus formation. Remember, in hemodynamic disorder, wherein we would identify the thrombus by the presence of the lines of Zahn, wherein you have the alternating patterns of dark red, light red colors, and this is associated with the red blood cell layer and fibrin. Okay? So this is hemorrhoid. So what are the conditions wherein hemorrhoids can occur? It can be associated with excessive straining during defecation. It can also be associated with pregnancy. Okay? So next we have slide 81, which is adenomatous polyp, or we simply would call it as adenoma. Okay, so there are several types of polyps in the gastrointestinal tract. We have the hyperplastic polyp, which is simply redundancy, increase in the number of colonic glands. And then we have the inflammatory polyp, which is associated with inflammation. And then we have the adenoma. The adenoma is characterized by the presence of epithelial dysplasia. It is always present. Okay? And it depends on the features that we see. So it can be mild, it can be moderate, it can be marked or severe, or a high-grade dysplasia, low-grade, mid-grade, or high-grade dysplasia. So how do we identify for the presence of dysplasia? So on the right side, this would be the normal colonic glands. Okay, so these are the simple tubular glands. The glands here would be lined by single layer of columnar cells with slightly elongated dark nucleus. However, if you're going to compare it with the other side, here you would see the presence of stratification, darker chromatin pattern, there are several mitotic figures present in this case. 1, 2, 3, 4. Although this is simply an index of cellular proliferation. Okay, so you have increase in the chromatin, increase in the chromatin pattern, so it makes it hyperchromatic. There is stratification of the nucleus. Okay, and the adenomas can be classified into 3 types depending on the architectural pattern. So it can be tubular, it can be villus, or it can be a combination of tubular and villus, which we would call as tubulovillus. Do you know how to identify which is tubular, tubulovillus, or villus? You simply look at the appearance of the makeup of the adenoma. If it's composed of this type of glandular pattern, it's called tubular. Okay? If you see the presence of the projections, then it's villus. So if it's a combination, then you call it as tubulovillus adenoma. Okay? So adenoma, these are adenomas are already termed as neoplastic polyps. Although, in neoplasia, it can still be benign or malignant. And there are 2 important characteristic features that would be identified with an increased correlation for risk for malignancy. And that would be the size. So, the size of the adenoma. 1 cm, very rare to have malignancy. But if it's 4 cm, there's a 40% increased risk for malignancy. Another would be the dysplasia. So if it's mild, there's less risk. But if it's high grade, then it correlates with increased risk for cancer. Okay? So let's go to the other side. Other slide, which is 209. In the manual, this is labeled as an adenoma. However, this is Peutz Jeghers syndrome. A Peutz Jeghers syndrome would be seen in adolescents with a median age of 11 years old, and this is associated with multiple hamartomatous polyps. Okay, so hamartomatous, it means that the nature or the portions of the polyp would be similar to the rest of the portions of, let's say, the gastrointestinal tract, or in this part, the jejunum. Okay, so it is not characterized by dysplasia. You can see the presence of goblet cells. Here we would see the presence of the normal single lining of columnar cells. Okay, but you can see the presence of polypoid, polypoid fragments. Okay, so you can see polypoid fragments in the area. There. This is the highest magnification. So you can see several polypoid areas. There. Okay. So this is Peutz Jeghers syndrome. Slide 209. So what are the features? Again, you do not see the dysplasia. Okay, you do not see dysplasia, single layer of epithelial cells. Goblet cells are numerous. Okay. And there are a lot of glands here. This one is another polyp. Okay, this entire thing is a polyp. Okay, and then this one is one big polyp. Okay, so the mutations that would cause Peutz Jeghers syndrome would be the STK11 inactivation. So next slide would be slide 35. we are now with adenocarcinoma of the colon. Okay. So of course, when we are talking about adenocarcinoma, we are talking about atypical cells that are forming what? Forming glands. Okay, always when we talk about adenocarcinoma, we always would think of atypical cells forming glands. So adenocarcinoma of the colon is associated with diet. Okay, so if you have less intake of vegetable fiber, high intake of carbohydrates and fats, you have increased risk for development of cancer. Aside from that, mutations would be also feature of adenocarcinoma, wherein we have the APC, adenomatous polyposis coli gene, and we have the MLH1 inactivation, which is seen with microsatellite instability. The colon can be affected at the proximal and the distal portion. If it's the proximal, because if it's on the left side, it is more associated with more proximal. It's seen in the cecum. Then there's a huge area there. Okay, it can be polypoid, it can be exophytic, and it's associated with bleeding. Okay, with iron deficiency anemia. If it's in the distal colon, it's associated with being annular. So it causes a decrease in the caliber of the lumen, causing changes in bowel habits, alternating patterns of diarrhea and constipation. Okay, so features here, you have fused glands. Okay, you have fused glands in this portion. Okay. Of course, characterized by presence of hyperchromasia. We have presence of necrosis and then necrosis. Okay. Our last slide for this session would be carcinoid tumor. Okay. So carcinoid tumor of the this is from the jejunum. This is characterized by being a well-differentiated neuroendocrine tumor. And most common sites we would have would be the jejunum, the appendix, and then the colon. So of course, the most common would be the jejunum. And a carcinoid syndrome can be appreciated in 10% of cases. Okay, so although we have carcinoid tumors, only 10% would manifest with carcinoid syndrome. What are they? The presence of cutaneous flushing, the presence of profuse sweating, the presence of abdominal pain. Okay, so what are the features of carcinoid? We can see the presence of fairly uniform round cells having irregular chromatin pattern. They're seen forming nests like this, ribbons, cords. Okay, and usually they are submucosal or intramucosal or intramural masses. Okay, and with regards to the location, mid-gut carcinoid tumors are usually aggressive. Those would refer to the jejunum or ileum. And the appendix would also be a common site for the carcinoid tumor. And usually what we do is we cut because usually the carcinoid tumor would be located at the tip of the appendix. Okay, so those are the slides that we have for this session. Okay, so kindly check on, it's going for that. So kindly check on the details in the book. Okay, so thank you and good day.